Welcome to this Society for Integrative Oncology webinar. I am pleased to introduce our presenter for today, Dr. Heather Greenlee. Dr. Greenlee is a behavioral scientist and translational epidemiologist whose work focuses on understanding what cancer survivors can do in addition to conventional care to improve cancer outcomes. She is the immediate past president of SIO and currently serves on the SIO Executive Committee. Dr. Greenlee trained in naturopathic medicine at Bastyr University in Seattle, Washington. She then went on to receive training in epidemiology at the University of Washington and Columbia University. She completed postdoctoral fellowships in cancer prevention and control at both Fred Hutchinson Cancer Research Center and Columbia University. Dr. Greenlee is currently an assistant professor of epidemiology at Columbia University's Mailman School of Public Health. Her research focuses on the use of complementary and integrative medicine and lifestyle modifications for breast cancer prevention and control, with a specific interest in Latina breast cancer survivors. Dr. Greenlee uses observational studies and clinical trials to study what women can do in addition to conventional treatment to prevent breast cancer, decrease side effects of treatment, and improve prognosis. Dr. Greenlee is an active member of SWOG within the National Cancer Institute's National Cancer Clinical Trials Network. Her work is funded by the National Cancer Institute, National Center for Complementary and Integrative Health, and Foundation. It's my pleasure to turn the presentation over to today's presenter, Dr. Heather Greenlee. Dr. Greenlee.
Okay. Sarah, can you hear me?
Yep.
Okay, terrific. All right, good afternoon, everybody. I'm so thankful that you're on the call with us. It looks like we've got a really good attending here. This is one of our SIO webinar series sessions, and what we do in these sessions is that we want to share with the oncology community the best in integrative oncology practices. And so I'm really excited today to share with you our clinical practice guidelines on the use of integrative therapies as supportive care in patients treated for breast cancer. These were published in the Journal of the National Cancer Institute monographs in November, and we presented these at the most recent Society for Integrative Oncology conference in 2014. Let's see here. So these guidelines, SIO has a long history of publishing integrative oncology guidelines. Prior guidelines were published by SIO starting in 2007, and these were general integrative oncology practice guidelines that weren't really based on a systematic review of the literature. This is really looking at best practices and what the evidence was to date on a series of integrative therapies. These were updated by SIO in 2009 and published in the Journal of the Society for Integrative Oncology. Interestingly, in 2007, SIO was invited by the lung cancer field, by the American College of Chest Physicians, to publish integrative oncology guidelines specific to lung cancer patients. And so these were published in Chest in 2007 and were updated again in 2013. And the link to these guidelines, we provided a link here that takes you to the SIO website to show you where, to give you access to these guidelines as they're published on our website. Now, one of the ways, there's many reasons why we publish guidelines, but one of the reasons is to get these out into the community for both practitioners and patients to have access to. And so SIO has been actively working with AHRQ to get our guidelines published on the National Guideline Clearinghouse. And so our prior guidelines are available in the National Guideline Clearinghouse. We are currently working with them to get our 2014 guidelines up and posted. So those will be posted very soon. We've also worked with what is now the National Center for Complementary and Integrative Health to publish our guidelines there. And so if you haven't visited their website, I strongly encourage you to do so. They have a website that shows clinical practice guidelines, and we are responsible, SIO is responsible for publishing 3 out of the 4 guidelines that are currently available for oncology. There's current guidelines on exercise for cancer survivors, integrative oncology and lung cancer, our 2009 general integrative oncology guidelines, and then the most recent guidelines that were published specific for breast cancer patients. So what exactly are clinical practice guidelines? So in 2011, the Institute of Medicine made the statement that clinical practice guidelines are statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care options. And so why as a society are we interested in addressing these? So first of all, we want to provide both clinicians and patients with a trustworthy tool for managing clinical problems. We want to represent the current state of the science. And for an organization like SIO, we want to increase our visibility, credibility, and impact in our professional community. So the IOM published a document on how to conduct, how to create clinical practice guidelines. And this is a very nice a diagram that they've created that shows that the first step is defining a clinical problem. And that leads really into a 2-pronged effort. The first effort is to develop a systematic review. For this, you need to assemble a multidisciplinary team, identify, assess, and synthesize the evidence, produce a systematic review report, or produce a systematic review, and then use that information to feed into the development of clinical practice guidelines. At the same time, you need to look at other evidence that's in the field. You need to incorporate expert opinion. You need to produce the guideline, and then that goes out into the community to guide better informed decisions among patients and clinicians. So there are 8 specific standards that the IOM has created for developing trustworthy clinical practice guidelines. The first, and I think that it's important to go over these because this really informed our process, and I think it's just important for the community to understand all of the effort that goes into creating these guidelines. So the first is to establish transparency. Nobody's going to believe or trust guidelines that are fuzzy and mysterious. We want the guidelines, people to know exactly where they came from and how they were formed and why they were formed. It's important to manage conflicts of interest. It's important to have a balanced group in the guideline development group. It's important to have systematic reviews be a fundamental aspect of the guidelines. It needs to establish evidence foundations in order to rate the strength of recommendations. It's important to articulate the recommendations in a standardized form and phrase so that compliance with the recommendations can be evaluated. It's important to have external reviewers that comprise a full spectrum of relevant stakeholders, and it's important for the guidelines to be updated on a regular basis, which SIO has now committed to do. So what did we do in SIO? So the history of these guidelines is that SIO had this history of previously publishing guidelines in 2007, 2009, and 2013. And we wanted to undertake this effort again, but we actually wanted to boost the methods by which we were going to do this going forward. And we wanted to follow the IOM process, and we wanted to be incredibly transparent in our efforts. So SIO assembled a guideline task force in spring of 2013. This was comprised of Gary Dang, who led many of the prior guideline efforts. Myself, I was the president at the time of SIO, and Susie Zick, who is our current president, but she was then the president-elect. And what we decided at that point is we were trying to think through what was the best next step for SIO to take in terms of developing guidelines. And our options were many. Really the 2 main options were, did we want to do a systematic review of all integrative modalities and therapies for all cancer types, at all points in time, which we could have done, but that seemed very large. Or did we want to do something that was more specific and probably more easily doable and more easily implementable from a procedural way of getting this out the door from SIO. And so we decided, so we identified a topic, and in the summer of 2013, we narrowed our focus down, and then we needed to establish our process for, SIO's process for developing the guidelines. And so we did this in the summer and fall of 2013. And so we identified areas of expertise that needed to be represented in our working group. We identified our multidisciplinary working group members. We developed a process to manage the conflicts of interests, and we developed a timeline for doing this project. And so for anybody who's ever done anything like this or done a large project, of course we absolutely underestimated all of the time that it took to do this. So we decided our topic was going to focus on the use of complementary and integrative therapies among breast cancer patients undergoing treatment. And the reason for this is that, as many of you on the call know, there's a large number of breast cancer survivors in the U.S. It's one of the largest cancer survivor populations in the U.S. We know that this is a cancer patient population that are high users of complementary and integrative medicine. Depending on what study you read, somewhere between 40 to 80% of breast cancer patients in the U.S. are using some form of complementary or integrative medicine. And breast cancer survivors are using complementary and integrative medicine for a multitude of reasons following diagnosis, including but not limited to preventing and treating side effects of conventional therapy, to improve quality of life, functional status, and emotional health, to increase the efficacy of conventional cancer therapies, for secondary cancer prevention, to meet the needs not addressed by conventional therapies, to treat comorbidities, and also for general health promotion. And so we knew, based on that, that we needed to have a wide representation of backgrounds and expertise in our working group to be able to address all of the reasons or all of the different modalities that breast cancer patients were using. So this process was co-chaired by myself and Debu Tripathi. Debu is a breast oncologist and leads breast oncology now at MD Anderson, and he's a SIO past president, and he's very involved. He's also the co-chair of the breast committee within SWOG, which is one of the NCI clinical trial cooperative groups here in the U.S. And so Debu and I co-chaired this, and we invited a number of individuals with specific backgrounds to join us. These are Linda Balneves, and I'm not going to read all of their areas of expertise. You can see that on the slide. But Linda Balneves, Lindy Carlson, Misha Cohen, Gary Dang, Don Hirschman, Matt Mumber, Jane Perlmutter, Jubal Seeley, Ananda Sen, and Susie Zick. You know, of note, one of the things that was very important for us to involve in the guidelines was to bring on a patient advocate, and so for the first time, the SIO guidelines group had a patient advocate involved, and so Jane Perlmutter did a terrific job there with us. But you can see here we had a whole host of individuals with both varying expertise in clinical background, you know, from integrative therapies to conventional therapies, people with clinical practice who are active clinicians. We had people who were active researchers with strong research backgrounds. We had a biostatistician on board. And so we really had a robust group of people to sit down and tackle this literature. So the next thing that we needed to do is to manage conflicts of interest. So here we needed to review potential financial conflicts of interest for all of our authors, including research support. We found that there are actually no financial conflicts of interest to disclose within this particular group. And we did note, and we note this in the manuscript, that some of the authors have actually conducted or authored some of the studies that were included in the review. So the prior SIO guidelines were organized by integrative therapy modality. So they were organized in terms of, you know, what does the literature on acupuncture say? What does the literature on mind-body interventions say? What does the literature on natural products say? And what we decided in this iteration of our guidelines, we decided to do things very differently. First, what we did is that we identified all of our interventions of interest explicitly. So we knew that we wanted to include natural products. We wanted to include all of the various mind-body practices. we knew that we wanted to include acupuncture, acupressure, electroacupuncture, massage therapy. We wanted to look at whole systems. But one of the things that we specifically decided to do was to exclude diet, physical activity, and energy balance. And the reason that we excluded those from this set of guidelines is that all of those have already been extensively reviewed and published in some very strong guidelines from the American Cancer Society, the American Institute for Cancer Research, and the American College of Sports Medicine. And because those had already been done so well by other groups, we decided that we did not need to recreate the wheel there, and instead we really wanted to just focus on the interventions of interest where we really had the most expertise. So we identified our interventions of interest, but what we did differently this time than from prior guidelines is that we focused on specific relevant clinical outcomes of interest. And here, and the way that we then subsequently organized the guidelines is that we organized them by clinical outcome. And the reason we did it that way is so that both clinicians and patients, if they had a clinical issue that they're grappling with, if they had a symptom or a side effect that they were working with, they could go to our guidelines and say, my patient has this symptom or I'm experiencing this symptom. What are the integrative therapies that are known to be beneficial or not beneficial for this particular condition? And so you can see here all of the different outcomes of interest that we selected for our review. And I'll say them: fatigue, gastrointestinal outcomes, gyne, hematological, lymphedema, neurological, neuromuscular, pain, psychological, quality of life, renal, skin, sleep, and vasomotor symptoms. Of note, we did not include immune parameters in these in our guidelines or in our review, and the reason for that is that even though we think that they're most likely important, nobody really knows at this time what happens if you modulate immune parameters, and nobody really understands how much we might need to modulate immune parameters to have any changes in clinical outcomes. And so what we're really doing here is assessing the literature on clinical outcomes that are known to be clinically meaningful to patients currently. So our search criteria is that we went to 9 databases that are listed here, and we searched for studies that included the following: that they were a randomized controlled trial, that they were published between January 1st, 1990 and December 31st, 2013. And I can say here, of course, there were some really terrific articles published in February and March of 2014, but because these were our parameters, we did not include that time. We had to delineate it. The article had to include breast cancer patients, it had to include some statement about breast cancer treatment, had to include a statement on the side effects and toxicities, and had to include a statement on complementary and integrative therapies. And you can go to the supplemental files of our manuscript that was published in the JNCI monographs, and on our supplemental files we actually have our full search criteria listed and reproduced, and so anybody's welcome to use that if it would be useful for them. And if you go to look at it, you'll see that it's incredibly comprehensive. So this is our search criteria. The rationale for starting January 1st, 1990 is that we had to put some sort of time limit on it, and we wanted to really look at the more current trials because we thought that that actually would represent more of the way conventional oncology is being currently practiced, and also, for the most part, most of the more recent trials in integrative medicine are higher quality now, and beginning in 1990. So our inclusion criteria for a trial was that it needed to be a randomized controlled trial, it needed to be available in English, that the manuscript had to be published in English. The trial itself had to include either more than 50% of breast cancer patients or to have reported the results separately for breast cancer patients, because we were really evaluating the effects of these therapies specifically among breast cancer patients. And that in the trial it was assessing the use of an integrated modality as an intervention during standard treatment with surgery, chemotherapy, radiation therapy, and or hormonal therapy, or that it addressed a long-term side effect resulting from diagnosis or treatment, and that the trial assessed one of our clinical outcomes of interest. We excluded other systematic reviews and meta-analyses from this. We really wanted to go to the original articles themselves. So our search results, be careful what you ask for, our search results resulted in almost 5,000 unique articles. So of all of these, initially our article titles and abstracts were initially screened by at least 2 reviewers to decide if we needed to then go and do a full review of the articles. The full text of the articles that met the criteria were assembled using an online database called Mendeley, and this actually was a wonderful system. This allowed us to share all of these articles remotely, and so if anybody's interested in doing this, I highly recommend this software product. It was terrific. It allowed us to store all the articles and leave notes there for each other in the articles and arrange them into different groups. Then our second round of screening consisted of a full text scan to further remove articles that did not meet our inclusion criteria. And so of all of those, 4,900 unique articles, eventually we narrowed it down to 203 articles that met our criteria for our final inclusion in the review. So once we had those 203 articles, what we did is that we developed a quality scoring system. And we did this based on 2 prior quality scoring systems that had been published, one by Haddad and one by Verhagen. And the reason for doing this is that just because it's a randomized controlled trial doesn't mean that it was actually executed well, or it doesn't mean that the methods used were as meaningful as they potentially could have been. So what these allowed us to do is to really assess objectively the quality of the studies. And then we use this information depending on the quality of the study in addition to the study results as reported. We use that to inform how we graded the strength of the evidence available for the study or for the individual combinations that we are looking at. So here you can see for the Haddad score, we looked, was the study randomized? Was the method of randomization described in detail and was it appropriate? Was the study described as double-blinded? Was the method of double-blinding described appropriate, maintained a double-blinding? Was there a description of the dropouts or withdrawals? And the modified scale, you'll see we actually expand upon that a little further. So we used the Haddad scale is up top and the modified scale is below. And this was a really interesting process. We had to talk through, some of the issues, as you can see in our scoring, for some of these modalities, it's not appropriate to blind. For some of the mind-body therapies, you can't blind. It's not the same as doing a drug trial. So we had to think through the various scoring system issues. So then we had to develop grades for our evidence. And so for this, we went to the U.S. Preventive Services Task Force, and they have a very clear guidelines for developing grades for systematic reviews. And it's important, I'm going to walk you through this because I think it's really important to understand what our individual grades indicate. So a grade A, the definition of that is that we recommend the modality and there is a high certainty that the net benefit is substantial based upon the evidence to date. And here the suggestion for practice is to offer and provide this modality. A grade B, again, recommends the modality, but here there's a high certainty that the net benefit is moderate, or there is moderate certainty that the net benefit is moderate to substantial. But again, based on the grade, we still suggest offering or providing this modality. The grade, so in terms of the highest grades, grade A and B really are the 2 highest clearly actionable recommendations from our guidelines. For the grade C, this recommends selectively offering or providing the service to individual patients based on professional judgment and patient preferences, and there is at least moderate certainty that the net benefit is small. So here, and then the recommendation is to offer or provide this modality depending on the individual circumstances. And here, this is where we have a lot, you'll see that we have a lot of our therapies or our modalities that we assessed have a grade C for specific conditions. And partly it's because either it showed that there was a low impact of the modality on our outcome of interest, but I think more importantly for a lot of these conditions that we were looking at, the evidence is really we can't make is inconclusive at this point. We can't make conclusions on the evidence, so we had to give it a grade C. A grade D is where we would recommend against the service, and that's where there's moderate or high certainty that the modality has no benefit, and so for this we would discourage the use of this modality. A grade H recommends against the service, but this time it's because there's moderate or high certainty that there's a harm that outweighs the benefits, and here again we would discourage the use of this modality. And the grade I statement shows that there's current evidence is insufficient to assess the balance of benefits and harms of the service. So evidences of lacking due to poor quality or conflicting evidence, or the balance of benefits and harms cannot be determined. And so here we also had to make quite a few I statements in our in the recommendations. So this here, so we finally we worked on this very diligently as a group, and these were published in November of 2014 in the Journal of the National Cancer Institute Monographs, and these were published as part of a special issue on integrative oncology that was coordinated by June Mao, who's currently our president-elect, and by Lorenzo Cohen, who is one of our past presidents. And they put together a really terrific special issue focused on integrative oncology. So if you haven't read the issue, I strongly suggest that you do that. But this is the the abstract specifically for our manuscript, looking at the clinical practice guidelines. And what I want to do is I want to call your attention to the supplemental materials that are also published. These are published on the JNCI Monographs website. They're open access. We also have a link to them on our website. But what is also embedded in there and is open access and also on our website are the 80+ pages of supplemental materials. What I just showed a screenshot here of one of the pages. Here what we do is that for each specific intervention for each condition, so this is showing the information that we reviewed related to anxiety and stress for breast cancer patients. For example, if you look at music therapy, there's 4 specific trials that we evaluated, list the population, the sample size, the details of the intervention, what the comparison group was, the conclusions from the study. It shows you here what our study quality score was, the outcome that was assessed, the primary outcome or the secondary outcome, and then it shows you what our recommendation and our grade was. And so, since these have been published, people have been asking some specific questions about our process, and so this will, this definitely gives you some, I think, some good details on how we went through and evaluated the literature, and shows you what we found. So now what I want to do is take some time to walk you through our specific findings, and to talk through some of the nuances of these. And so, as I said earlier, the way that we organized the guidelines is that really we focused it on clinical outcomes of interest. So the first one that we addressed was anxiety and stress reduction. So for these, we were able to give grade B recommendations, and if you remember, grade B suggests that these be provided. We were able to give grade B recommendations for music therapy, for meditation, for stress management, and for yoga. And you can see that there are some caveats around these recommendations. And so the data for music therapy, we were able to recommend music therapy for reducing anxiety during radiation therapy and chemotherapy sessions. Meditation is recommended for reducing anxiety in breast cancer patients and individuals undergoing radiation treatment. Stress management is recommended for reducing anxiety during treatment, but longer group programs are likely better than self-administered home programs or shorter programs. Yoga is recommended for reducing anxiety in breast cancer patients undergoing radiation and chemotherapy, and is suggested for fatigue patients. And then for grade B or for grade C, and this really is where it's recommended depending on the patient preferences and the patient clinical situation. Here we gave grade C's to acupuncture for reducing anxiety and fatigue breast cancer patients. Massage can be considered for short-term reduction of anxiety in breast cancer patients, and relaxation can be considered for treating anxiety during treatment. And for this, I'm just going to review really the grade. I'm not going to go through all of the details. You can please refer to the guidelines themselves for additional details on additional grades, and really for looking at the specific studies that we included in these recommendations. So for depression and mood, grade A, we were able to give grade A recommendations for meditation, relaxation, and yoga. So meditation, particularly MBSR, or mindfulness-based stress reduction, is recommended for treating mood disturbance and depressive symptoms in breast cancer patients undergoing radiation treatment. Relaxation is recommended for improving mood and depressive symptoms when added to standard care. Yoga is recommended for improving mood in women undergoing radiation and chemotherapy, and for fatigued breast cancer patients in addition to standard care. We are able to give grade B recommendations for massage and music therapy for depression and mood. Massage is recommended for improving mood disturbance in post-treatment breast cancer patients, and music therapy is recommended for improving mood in newly diagnosed breast cancer patients. And you can see we have some of these caveats built in there, and it's really based on the evidence that we could assess in the different trials that had been conducted. We gave grade C recommendations for acupuncture for improving mood in postmenopausal women experiencing hot flashes or fatigue. Healing touch can be considered for improving mood in breast cancer patients undergoing chemotherapy, and stress management interventions with or without exercise can be considered for improving mood in breast cancer patients. And again, some of these specifics, for example, acupuncture can be considered for improving mood in postmenopausal women experiencing hot flashes or fatigue. These are really the way that where this recommendation came from is that this was a study looking at the use of acupuncture for hot flashes or acupuncture for fatigue, and I believe in these particular studies they had depression and mood as secondary outcomes, and so we were able to make that recommendation here based on the body of literature. Next, moving on to fatigue, we were able to give a grade B recommendations for energy conservation counseling for the treatment of fatigue, grade C recommendation for American ginseng, acupuncture, and qigong. American ginseng can be recommended as an herbal approach for the treatment of fatigue in breast cancer patients. Acupuncture can be considered for the treatment of fatigue after the completion of cancer treatments, and a modified form of qigong can be considered for the treatment of fatigue in breast cancer patients. Unfortunately, we had to give 2 grade D recommendations. Acetyl-L-carnitine is not recommended for the treatment of fatigue due to a lack of effect, and I can vouch for that study. That study came out of our group here at Columbia. And then guarana is not recommended as an herbal treatment for fatigue, again due to the lack of effect. And so we were able to look at their literature and find some cases where therapies that were hypothesized to have an effect, they were studied and they were shown in fact not to have an effect. For sleep, we give a grade C. Again, so this means consider using it based on the patient's individual symptoms and preferences. Stress management techniques can be considered for the treatment of sleep disruption, and yoga can be considered for the treatment of sleep disruption. So we're very interested in looking at the use of integrative therapies and integrative approaches to improve quality of life and physical functioning. So meditation received a grade A for improving quality of life among breast cancer patients. And then you can see there's a whole host of individual treatments that, and I won't read over the whole statement, but you can see there's a whole host of treatments that received a grade C for improving quality of life and physical functioning. So you have acupuncture, guided imagery, mistletoe, qigong, reflexology, stress management, yoga, and exercise awareness. And then for here, grade D, energy conservation cannot be recommended for improving physical functioning among breast cancer patients due to a lack of effect. So this was tested and it was shown not to be useful. Moving on, so chemotherapy-induced nausea and vomiting. We were able to give both acupressure and electroacupuncture a grade B here. So acupressure can be considered to be used during chemotherapy-induced nausea and vomiting, as well as electroacupuncture. And the studies there are rather rather robust. Grade C, we gave ginger a grade C for patients receiving chemotherapy, and also progressive muscle relaxation received a grade C as well. And I want to see, I see now that there's a number of questions that are popping up, and what I'll do is I'll go through, and I'm almost done answering or presenting our findings, and I'll go through and answer some of the questions at the end of the presentation. And here we gave glutamine, received a grade D, and it's not recommended for use for breast cancer patients receiving chemotherapy because it was shown not to have an effect in the studies that have been conducted. So pain, I think as everybody knows, pain can be a large issue for patients undergoing breast cancer treatment. And so there's a number of issues, a number of modalities or therapies that received a grade C for pain. We didn't have any modalities that received a grade A or B. And so here for pain we have energy and sleep enhancement for pain associated with chemotherapy. Massage and healing touch can be considered for pain associated with chemotherapy. Music therapy can be considered to relieve pain associated with surgery. A physical training program that includes a mind-body component can be considered for pain associated with surgery. Hypnosis can be considered for surgery-associated pain. Acupuncture can be considered as a non-pharmacologic approach to pain that's associated with the use of aromatase inhibitors. As you may know, aromatase inhibitors have been shown to be very useful in increasing the survival of breast cancer patients, but they often cause a very debilitating joint pain. And so acupuncture has been shown to have some moderate effects at reducing that joint pain and the associated musculoskeletal symptoms. And then also electroacupuncture can be considered as an approach to the aromatase inhibitor-induced musculoskeletal symptoms. Neuropathy, so as I'm sure many of you know, neuropathy is a big problem, with a significant problem for a lot of patients undergoing different forms of chemotherapy. And there's one study that actually, again, was conducted here at our group at Columbia where we tested acetyl-L-carnitine for preventing neuropathy in breast cancer patients. And what we found actually in that study and what we report here in the guidelines is that acetyl-L-carnitine was actually shown to increase neuropathy in the patients that were using it. So the guidelines suggest do not use acetyl-L-carnitine for preventing neuropathy. And there's a lot of interest in, we put this here, there's a lot of interest here on the use of other modalities for preventing neuropathy, and at this point we stated that there was insufficient evidence for electroacupuncture or vitamin D, omega-3 fatty acids, and vitamin E. So for lymphedema, there's grade C evidence for using laser therapy for the treatment of lymphedema in breast cancer patients, and also grade C evidence for manual lymphatic drainage and compression bandaging. Manual lymphatic drainage is shown to be equivalent to compression bandaging, which is a conventionally used treatment. So we put that manual lymphatic drainage can be considered for treating lymphedema, especially for patients who have sensitivity to compression bandaging. So hot flashes, grade C, acupuncture received a grade C for decreasing hot flashes, and electroacupuncture also received a grade C for decreasing the number of hot flashes. Grade D, soy was not recommended for the treatment of hot flashes in breast cancer patients due to the lack of effect. And then our last recommendation is on acute radiation skin reactions. So there's grade D evidence, again, showing that it does not work for both aloe vera and hyaluronic acid cream. So these are both neither of these is recommended as a standard therapy to prevent or treat acute radiation skin reactions. So in conclusion, or nearing conclusion, what we were able to do here, and if you go to the guidelines as they were published, you'll see there that where we list all of the, in a clear table, we list all of the recommendations, and then the supplemental materials will show you all of the other modalities that we looked at and that we assessed where there was insufficient evidence, and it's clearly laid out in the supplemental materials. I didn't have space to do that on our slides today, and we didn't have space to actually publish all of that information in the single manuscript itself that was published in the monographs. But you'll see that what this provides is this really is an up-to-date summary of randomized controlled trials with a very defined grading system, but there are quite a few limitations. What we weren't able to include is the older literature. We weren't able to include the meta-analyses and the previous reviews that had been completed. We had to exclude trials that had a minority of breast cancer patients. It's very possible that even though we had a very extensive search criteria for our system, we may have missed some trials using different keywords, or we may have missed some trials because they were associated with a cancer therapy that we didn't include in our search. And we did not include all modalities in our assessment. For example, we did not include spirituality as a modality that we assessed. And there are also some important caveats. It's very important, and I think the working group that worked on this, that in order to be able to create future recommendations and really create future guidelines, we really need our trials going forward to use standardized therapies whenever possible, to have very clearly defined definitions of the symptoms that they're assessing as well as the eligibility criteria. We have to have very, very clear outcome measures that are well defined and very clear toxicity assessments. I think we have a long ways to go from a methodological standpoint to standardize these things across the board so that we can more easily compile our information when we're compiling guidelines going forward. And then finally, it's important for everybody to acknowledge and to understand that the use of these guidelines are not entirely prescriptive. This requires clear judgment, shared decision-making, and a really clear risk-benefit analysis on the part of both the practitioner and the patient, depending on a patient's situation. So, for example, it's really important to assess where the patient is in their prognosis. And a patient with early stage breast cancer has a very different prognosis than a patient with very late stage breast cancer. And so, depending on their prognosis, that can really help inform the risk-benefit analysis of using these modalities, especially modalities that don't have a very strong evidence base at this point. And then we would strongly suggest that any patient, in any clinical situation where these modalities are being used, that the patients are followed up, there's a clear surveillance of their use of the modalities and any potential interactions, and that that adjustments are made as needed to what patients are being recommended to do. So we published these guidelines in November of 2014, and we had a very clear dissemination plan. We want to get this information out. We want really this to expand on the evidence base for integrative oncology, and we are hoping that this will inspire other groups to write guidelines, and we're certainly in SIO planning on writing future guidelines ourselves. So we published this in the Journal of the National Cancer Institute monograph. This is open access. We had press releases to many media outlets. We got some pretty good coverage. We're in Time Magazine's online forum. We've submitted these to national guidelines repositories, and these are posted, as I said, on the NIH website, and we're in the process of getting this up and running on the AHRQ website. We are in the process of developing patient and provider-friendly materials so that this material can be easily disseminated. And I think this helps show that we are really advocating for high-quality integrative oncology research. One other thing that we'll do after the conclusion of our webinar today is that we'll post these slides that I'm presenting today on the SIO website, and they'll be open and they'll be available for other folks to use. Our hope is that folks are going to take these and go use them to make presentations at their own institutions on the evidence of these integrative modalities to date. So in conclusion, we feel strongly that clinical practice guidelines provide an aid to making complex clinical decisions. These clinical guidelines will improve the ability for both patients and clinicians to make informed healthcare decisions. And the Society for Integrative Oncology aims to be the leader in developing trustworthy guidelines focused on integrative oncology. So to create these, it took a whole team of people. So all of us who were authors on the guidelines had a team of people behind us who were helping us pull all of this information together. We had a whole host of both internal reviewers and external reviewers who served as experts to give us their feedback, and we had great support from the SIO Executive Committee as well as from JNCI. We really had tremendous support there. So I'd like to end here. I want to thank all of you for participating in our webinar. And you can see here I have the link here again listed for where you can access the guidelines yourself. And what I'm going to do now is to go ahead and try to answer some of these questions that have come up. So if anybody has any more to add, please do so. So I see a question here about asking how relaxation is defined. That's a good question. It really depends on the individual study. So I think just loosely, we have relaxation therapies. We were having the discussion about this earlier today. Some of them involve hypnosis. Some of them involve guided imagery. Some of them involve deep breathing. It's a very broad term, and so I think you have to really go to some of these specific studies to see how they defined it in their patient population where they're doing their studies. There's another question here that asks, what activities are grouped under relaxation and what activities are grouped under stress reduction? That, again, we'd have to go back to the specific studies to see that. I think there's a lot of crossover I'm not a mind-body expert, but there's a lot of crossover in some of the mind-body techniques. So again, I think we'd have to go back to the original studies there to see how they were operationalizing those in their specific trials. But I think, I think relaxation is trying to achieve very loosely a state of relaxation, whereas stress reduction is very much more specifically I think relaxation can be focused on, physical relaxation, where stress reduction is really usually focused specifically on, mental stress reduction and doing that. The next question asks, is there any concern with the potential phytoestrogenic activity of ginseng, especially in ER-positive breast cancer? Yes, there has been concern with that. If you go to the article, we referenced some in vitro studies that have been performed. At this point, there really have not been any long-term longitudinal studies performed, and you'll see that we added some caveats in the recommendations about the use of ginseng for ER-positive breast cancer. This is not my specific area of expertise, but there is some concern there, but it's not clear. There's debate, so this is very much open for debate right now, and I will leave it at that. And then the last question here, oh no, there's a few more. There's a question on the route of administration for mistletoe in the quality of life studies. I actually don't know off the top of my head. We'd have to go back and look at the specific studies there on mistletoe. And let's see, go through. There's a question about different types of yoga. So there are many different types. The question says regarding yoga, there are many different types of yoga offered in the community. Gentle yoga appears to be useful and relatively safe. However, in your review, did you identify another school or type of yoga that was most commonly used in the RCTs? The yoga studies were really across the board, and one of the issues that we struggled with here is that for many of these different modalities, there are not, across the board, each study, invests a different type of yoga or a different form of an herbal treatment or a different acupuncture protocol. So what we're really doing here is we're trying to be general and knowing that there's a risk in being general. So we didn't see in our trials, for example, that there's one type of yoga that was showed to be particularly useful. We thought it would be more useful when we were writing these guidelines to talk about yoga more broadly. But again, to get all of that specific information, you'd have to go look at the specific articles themselves. And so we think that the information that we provided in the supplemental materials will provide you with a little bit more detail about the specific interventions. And if you really want to get the exact details of the intervention that was assessed, then you can go and you can do that. You can do that by going to the original articles. Somebody's asking where would they get additional information on nutrition and also on botanicals. So to get additional information on nutrition, the American Institute for Cancer Research has some really terrific information on their website, and that's aicr.org. The American Cancer Society also has some very useful information for cancer survivors on nutrition. For botanicals, at this point, from the SIO's perspective, we've assessed the literature on botanicals specifically for breast cancer, and we summarize what we've found to date in terms of the clinical trials, and we put that in our supplemental materials. Unfortunately, there just isn't that much information that's been presented in terms of randomized clinical trials. There really wasn't enough for us to assess at this point. And so what our recommendations are at that point is to go look at the information that's been provided and to start there, and to work closely with trained practitioners if individuals are interested in using botanicals going forward. Let's see, looking at some of the other questions. So there's another question here that asks, on the basis of this work, have the authors prioritized the research questions most deserving of additional research? So we do talk about that a little bit in the guidelines. We think that certainly the strongest evidence to date that we have is on the use of many of these mind-body therapies for more of the mood, depression, psychological outcomes, and that's really just based on the number of studies and the strength of the studies to date. We think there's a huge potential there for acupuncture and pain management, and potentially for fatigue and chemotherapy-induced nausea and vomiting. That showed to be very strong. There's some really provocative data out there on some of the quality of life measures. The use of mistletoe was really intriguing. And some of the natural products, I think that there's a lot of work that needs to be done in the natural products. I know, some of the work that I do outside of this is we do descriptive studies to talk about all of the various natural products that cancer survivors are using, and people are using a lot of products, and there really is a dearth of evidence right now on the effects, both the short and the long-term effects of natural products. And so I think there's a lot of work that needs to be done there, but that's going to take, there's a lot of additional preliminary work that needs to be conducted in order to move those large trials forward. But I certainly think there's a lot of potential for the mind-body therapies to be rolled out, as well as acupuncture right now. And I think those are the questions right now to answer. So I just want to thank everybody for taking the time to participate in this SIO webinar. We are holding these on a regular basis going forward, and thank you so much for participating. And I strongly encourage, if you are not already a member of the Society for Integrative Oncology, to get involved. We're a very active and multidisciplinary and I think engaged and provocative society of individuals, and so we hope we're actively working to grow our membership and incorporate folks from a multitude of communities to participate. I think if you don't know, our main event that we hold every year is our international conference, and this year it will be in Boston, and it will be in October in Boston, and will include both an additional day that we're holding jointly in association with the Society for Acupuncture Research and as well as the Fascia Society. And so that is going to be a fantastic conference, we think. So thank you very much for your attention, and I will turn this back over to Sarah.
Great. Thank you so much, Dr. Greenlee, and we look forward to seeing you all at our next webinar. Definitely check out our website, and we will have things posted there. Thanks a lot. Bye-bye.